Welcome to Module 3 in the NPSF Certified Professional in Patient Safety Review course. Each module in this series addresses one of the 6 patient safety domains that are included on the CPPS exam. This module will discuss external organizations that impact patient safety and summarize some of the key national patient safety goals established by the Joint Commission. The material was adapted from a presentation given at the 16th Annual NPSF Patient Safety Congress. The presentation was given by Karen Garvey, Vice President, Quality, Safety, and Performance Improvement, Parkland Hospital and Health System, and Donna Jenkins, Patient Safety Staff Specialist, Edward P. Lawrence Center for Quality and Safety, Massachusetts General Hospital. The content outline for the domain External Influences on Patient Safety is A. Articulate current national patient safety goals, which are referred to as NPSGs. B. Assist work units in implementing NPSGs. C. Maintain current knowledge of external agencies that issue guidelines on patient safety. D. Provide patient safety content expertise in continuous readiness related to accreditation and regulatory agencies. And E. Promote compliance with requirements related to reporting serious occurrences and reportable events to appropriate agencies. The items in the content outline are addressed in 2 objectives. 1. Describe the role of external agencies in providing guidelines and setting regulatory requirements for patient safety. And 2. Identify methods to maintain continuous organizational readiness for external review and accreditation. As most of you know, for the last few years, there have been widespread and growing concerns about the quality and safety of healthcare in the United States. Many people are concerned about the rising costs of care and the difficulties in controlling those costs. Additionally, attitudes about healthcare delivery and financing are changing among most stakeholders. For example, Massachusetts enacted a rule that recommended disclosure, apology, and recompense following an adverse medical outcome. The idea was, we'll make it up to you in some way, and we promise not to let this happen again. And many of the injured patients saw dollar signs. So at any moment, a healthcare provider might get a phone call asking, "What are you going to do for me money-wise?" The stakeholders are not just the insurers, but also patients and family members who are impacted by the errors and harm. Purchasers, payers, and consumers are demanding much greater transparency and accountability. Patients want to know, how are we going to make sure this never happens again? They are holding providers accountable not just for the error itself, but also for the prevention of that error going forward. If you're wondering who's out there messing in our soup, there's a whole bunch of folks. It's an alphabet soup of consumer groups, the Institute of Medicine, the Departments of Public Health in various states, Leapfrog, the Centers for Medicare and Medicaid Services, the Institute for Safe Medicine Practices, the Agency for Healthcare Research and Quality, and many others. There are a number of groups, this is only a small portion, who really care about how patient care is delivered and are concerned about patient safety. Our first response when the regulators are standing in our doorway is not one of joy, but they really do fulfill a role. They have a role of public oversight for healthcare entities and providers. Without them, it would be a messy free-for-all. We talk about standardization and how difficult it is to get things standardized within our organizations. The role of regulators is to say, if it's good enough at the local level, it's good enough at the larger level. We need to help you people standardize how you provide care and maintain safety. There is an endless alphabet soup of healthcare regulators. This includes the professional organizations that may come in and evaluate a specific program and the Centers for Medicare and Medicaid Services, also called CMS. When a healthcare organization has been accredited by a CMS-approved organization, CMS deems the facility as having satisfied the health and safety standards component of the Medicare certification process by virtue of their accreditation through the CMS-recognized Deemed Status Program. If you are seen by another deeming organization, CMS can pop in and say, "We want to be sure that your deemed organization is doing the right thing," and then you're back through a large evaluation yet again. All of the regulators have a defined authority to oversee some aspects of our operation and practices, including access to people, facilities, and records. How much they see in terms of safety reports is based on the peer review protection within your state and organization. But they do have the right to know what's going on, as they are often the people paying the bills for the care being provided. The largest and most significant regulator for most of us is the Centers for Medicare and Medicaid Services, or CMS. They are setting minimum standards as a prerequisite to payment, so the initial goal is financial. CMS is using our tax dollars, which they don't want to waste. So how do we make sure that the care being provided is quality, safe care? State departments of public health often do the local work of CMS by enforcing the conditions and participation of on-site surveys. For example, in Massachusetts, a renal dialysis unit would be reviewed by the Massachusetts Department of Public Health as a representative of CMS. But they also have an interest in patient safety systems. So if there was a serious reportable event, the Department of Public Health may also come in to investigate that specific event rather than the program. Often, you'll hear us refer to the Joint Commission as one of the larger deemed organizations that will accredit hospitals as being in compliance or not in compliance with CMS conditions and participation. So its authority comes from CMS, but it is not the only deemed organization. Other organizations may be visiting you on a regular basis, either as a surprise or planned visit, most likely a surprise. They often have a specific focus. For example, there are those that are specific to ambulatory surgery centers and those that are specific to home health organizations or hospice. Each has a set group of standards that you are required to adhere to. For most of these organizations, standards focus on patient safety or can be looked at from a perspective of patient safety. One of the things that is relatively new on the scene as part of an opportunity to share information across organizations in a safe and protected way is the advent of patient safety organizations. The role of the patient safety organizations was really defined through the Patient Safety and Quality Improvement Act of 2005, which allows organizations that fall under the Patient Safety Organization or PSO designation to share information in a protected manner across organizations. The goal is that we learn from each other. So if we have, for example, a monitoring event, we can talk to someone else with the same kinds of monitoring issues. If we have a medication safety event that's related to a particular brand of pump or a particular medication, we need to be able to talk to everyone else about that. By asking, how did that happen in our hospital? We are learning from each other and can spread that information. What happened in the federal area now is that if you're using something as the patient safety work product within the PSO, that becomes protected. There are some issues with that. It means that if you talk about that information outside the area of the PSO, you can personally be fined $11,000 for each time you talk about it outside the PSO peer review protection. AHRQ is the organization responsible for certifying and listing agencies. There are 80 PSOs in 29 states and the District of Columbia, but it doesn't matter where you're located, you can go across states and it can operate nationwide. Some are very specialty specific. Some are broader. The goals are to provide analysis and support, compare reports, and provide education and network opportunities. The Office of Civil Rights is responsible for the enforcement and administration of the confidentiality protections within the PSO regulations. You may not disclose patient safety work product outside of the PSOs, and if you do, you will be writing a check for $11,000. One of the things we really start to think about is how do we implement what the regulators are asking of us. We talk a lot about the Joint Commission and their national patient safety goals, but if you look at the Joint Commission standards, over 50% of them are patient safety focused. So again, job security for those of us in patient safety. There are things we need to be able to know and do. When you look at the national patient safety goals, these have been going on for quite some time now. They were first established in 2002 by the Joint Commission with implementation in 2003. They have not changed significantly, although some have been added. When we look at the current list of goals, we realize that we have really not done what we need to do with the basics at this point. They have added some new ones, and they have backed off on some they originally applied. For instance, they had originally come out with the goal of medication reconciliation in the ambulatory setting, and it was absolutely impossible to implement. So they went back and said, "We haven't given you the tools, we don't know quite how to do this yet, let's revamp that." So there are some changes, but they are not significant because we haven't reached the goals. The intent of the National Patient Safety Goals is really to assist organizations in addressing the specific areas of concern. What we will include here are the ones that are specific to hospitals. The Patient Safety Advisory Group is a multidisciplinary team that was brought together to develop and update the goals. It works with the Joint Commission, looking at what the emerging patient safety issues are, so you'll see the alarm management issue has been raised. It's something people have been talking about for a very long time, but no one seems to have been able to address it in a way that's been effective. When you hear these alarm stories repeating from organization to organization, you know we haven't licked it yet. And some organizations have actually pulled together a whole team specifically to look at NPSGs. For example, one organization has a group called Excellence Every Day. The group was started because a few years ago, the organization got a really bad review from the Joint Commission. Instead of doing what was traditionally done, which was to get ready for the next time the Joint Commission is coming, the organization decided, let's stop that. Let's be ready for the next patient, not the next regulator. That is the goal of patient safety, to recognize that the regulators are back there to say, as a public, are you keeping us safe? But the patients are coming to us to be safe every day. So how are we making sure that we are implementing that? Within this hospital, a group of multidisciplinary clinicians and administrators are responsible for communicating on a continuous basis. How are we doing with national patient safety goals, and what are our opportunities? So some of the things that were done in regard to this was the implementation of very routine and extensive tracers within the organization with executive level involvement. So there will be a team of representatives from the hospital's Center for Quality and Safety, along with clinicians and physicians, nurses, and respiratory therapists who will go out and actually do a tracer and review how the organization stands. The organization also uses its safety reports and the trends that are being seen with regard to national patient safety. It uses an electronic form for submitting safety reports, and within it, they are able to identify whether a particular issue is an NPSG. Then they can run a report to see where they sit with voluntary safety reports. When you ask people if they are actually adhering to all the NPSGs, the answer is absolutely. But what this organization found in observation is not so much. This is usually the case with the use of checklists and all the other things that are being implemented. When you go out and look at what a person is doing, they are not adhering to the degree that they believe they are. So this was an opportunity to go back and give continual feedback to the staff. For example, with the universal protocol, the checklist could be completed and all the boxes checked, but it's difficult to be sure that all the steps were really completed. So observation was implemented to be sure that each step on the checklist was truly and correctly completed. The NPSGs are updated annually, and they focus on emerging patient safety concerns. They also provide information on how to address the issue. It's not just saying, here is a problem, you go figure out the solution. Instead, the NPSGs say, here are some of the best evidence-based information on how to address the issue. Hospitals and facilities are then surveyed on implementation. We need to start doing a gap analysis to determine where we stand versus where we think we stand versus where we should be. There are various types of NPSGs. Then there are the universal protocols, which have been an addendum. Here are the NPSGs, and here are the universal protocols. An article was recently published in the New England Journal of Medicine that basically said, checklists don't work. One response to address people's concerns about this article might be to mobilize a group of stakeholders to review the literature and say, yes, in fact, checklists do work. There were definitely issues in the way the survey for the New England Journal of Medicine article was done, and in the way the results were published. You may want to read this article. There are lots of articles out there supporting the Universal Protocol on the use of checklists. Checklists are an opportunity to be given permission to communicate. That's really what they're about. So when we go back to the NPSGs, it's not about that checklist and those bits and pieces, it's really the permission, the psychological safety to say, you know what, I really think we skipped a step. Another big issue is medication labeling. This is challenging, particularly because it's labeling on the field, so that's a new addition to the NPSGs. And then in 2014, clinical alarm safety was added in. So here are some of the goals going forward. The first is to improve the accuracy of patient identification. So many of our safety reports are about the use of the two patient identifiers. The number of mislabeled lab specimens that get through our system are legion. This has so much to do with the frontline person and that human step, and how do we hold people accountable for it? It's no longer an education issue, but an accountability issue, and how do we move it to that? So it's the use of the two patient identifiers when providing care, treatment, and service. It's also about eliminating transfusion errors related to patient identification. And these do still come through every now and then because that frontline piece is problematic. The second goal is to improve the effectiveness of communication among caregivers. In this particular goal, they are talking about the reporting of critical values of tests and diagnostic procedures on a timely basis. This involves communication, not just between the provider and the performing lab or radiology department, but also between the provider and the patient. We have not solved this problem. We are now talking about the difference between critical and clinically significant. There are critical things. For example, we will tell a patient if their potassium is 8. But we might not tell them that it's 2.5 yesterday, but 5 today, because it has not yet hit our protocol for critical. So it's those things we're trying to address, and how do we deal with those kinds of issues? There's also a goal to improve the safety of the use of medications. This involves labeling all medication, the medication containers, and solutions. The challenge has been on the sterile field and the preoperative environment and any procedural setting. A related goal is reducing patient harm associated with anticoagulant therapy. Here again, the high-risk medications keep raising their heads. One organization had a patient death related to the use of leparudin, and it was really preventable from the very start. So as we look at how we reduce that likelihood of harm, it's really taking those high-risk medications by the throat and strangling them until we get them under control. Another issue is medication reconciliation, trying to maintain and communicate accurate patient information. As we cross boundaries with automated systems, this becomes much more of a challenge. You may have a computerized provider order entry system, but when the patients come from the recovery room to the inpatient unit, you need to make sure the meds are reconciled so you don't have patients from the general medical unit suddenly getting the drugs meant only for recovery room use. So it's about making sure communication is happening across all the boundaries, not just at the time of discharge, although it is significant there as well. Also important is reducing the harm associated with clinical alarm systems. This involves finding those opportunities to monitor the people who are appropriate to monitor. The amount of alarm fatigue is absolutely incredible, so it's important to be able to step back and say, what is it we need to do about this to mitigate that risk and make sure people are appropriately monitored and that the settings are appropriate for that patient. You want to make sure you're not monitoring that totally healthy athlete with a resting heart rate of 45 and have your alarm set at 50, because that just drives everyone crazy and they end up no longer hearing the alarms. Goal 7 is related to reducing the risk associated with infections, and that's looking at complying with the CDC hand hygiene guidelines. Again, it seems like such a simple thing. Please do hand hygiene. But it's not as simple as that. Just like labeling at the bedside, it's really that human interface. So the goal has been to also mobilize patients so they are aware of the risk of infections and they can be part of the team to challenge the healthcare professional. We also need to start implementing evidence-based practices, particularly around multi-drug resistant organisms. We need to implement evidence-based practices to prevent the central line bloodstream infections. We need to implement the central line checklist to make sure people are not breaking the sterile field. We also need to implement the evidence-based practices for preventing surgical site infections and to implement the best practices to prevent catheter-associated urinary tract infections. Get them out as soon as possible. There are lots of guidelines within each of these to help you. Goal 15 is to identify the safety risks inherent in the patient population. So focusing specifically on the patient at risk for suicide and the need for suicide screening at entry into the organization, risk for suicide, and then appropriate actions being taken at that time. And if the patient wants discharge, be sure they are given the proper resources if they are at risk. So you need to start to look at whether you are ready and whether it really is the goal of the organization. As an example, one hospital has a bunch of quality boards of trustees and a quality care committee. The Board of Trustees also participates in the Quality and Safety Committee. The state in which this hospital operates mandates that the hospital have a patient care assessment or Quality and Safety Committee, and the Board of Trustees is represented there. The hospital also has a Quality Oversight Committee, and within that they have an Excellence Everyday Coordinating Committee and a Safety Committee. Within the whole organization, each of these groups is represented by some very different groups so that there is a different voice being heard in each of the various settings, but they all feed up into the Board of Trustees. This hospital has developed, within each service, a regulatory readiness page. This talks about when the next survey is due and the need to really be ready every day for the patient. This is a way of informing the staff about new goals and new regulations that are happening within the hospital. And it provides people the opportunity to give feedback and have that conversation also within staff meetings. Thank you for listening. This concludes Module 3.